on molecular diagnostics and theranostics. These are my disclosures. And you already heard two excellent talks providing background for molecular basis for thyroid differentiation and expression of thyroid differentiation markers and sort of nuances of how really molecular profiling can, at least, at this early stages, predict the response to radioactive iodine. In my talk during the next 25 minutes or so, I'm going to look at this issue with somewhat different perspective, not really different from the perspective of something that we can now use clinically or are close to use clinically, because to run analysis for thyroid differentiation scores, look for additional markers of loss or gains on chromosome, really it's not feasible now in the clinical setting. But what we have histology, and in many cases we can have basic molecular profiles. And I want to sort of discuss the same issues that have been already covered by speakers earlier today, but from the perspective of how this information, more available information, can help us to at least to predict to some extent response to radioactive iodine. So I'm going to talk about molecular classification based on of thyroid cancer based on early driver mutations, and specifically discuss BRAF-like, RAS-like, and copy number alterations-driven tumors. Then we are going to talk about impact of late mutations, and particularly TERT, on differentiation. I think it is very important. Then we talk about how frequent we see a molecular signatures that predict sensitivity and opposite resistance to radioactive iodine treatment. And I'll finish with giving some thoughts on the genetic variability and if primary thyroid cancer analysis can substitute and predict what's happening in metastatic tumor fossa. So I start with a general overview. Today we are talking about follicular cell-derived thyroid cancer, obviously not medullary carcinoma. And you know that these tumors, these cancers, are subdivided into well-differentiated, poorly differentiated, and anaplastic carcinoma. For well-differentiated cancer, you know that the most common type is papillary carcinoma, followed by follicular carcinoma, and Hürtel cell carcinoma in the current WHO classification is considered a separate subtype, not a variant of follicular carcinoma, for a good reason, because molecular genetics of this tumor is very different. Then tumors can de-differentiate and give rise to poorly differentiated carcinoma and to completely undifferentiated anaplastic carcinoma. And we know that overall, with the loss of differentiation that we see morphologically, I mean, there is obviously loss, it's a very well-known loss of radioactive iodine avidity. But we need to focus on this group, on group of well-differentiated cancer, in order to really try to sort out what markers we can use to try to predict the response to treatment in these tumors. So we started our discussion with papillary thyroid carcinoma, the most common type of thyroid cancer. This TCGA diagram, I'm sure you've seen multiple times, but I just will go one more time to be sure that we are all sort of, on the same page. So this is an oncoplot that shows 400 papillary thyroid carcinomas. Every column here is one tumor, and every row is a specific mutation or genetic event that was found in this tumor. And when we start with point mutations, a large proportion, 30 to 60 to 70% of all papillary carcinomas have BRAF V600E mutation. This is the most common alteration in these tumors. Why I'm saying 30 to 70 range? Because in different countries, this proportions is different. In Northern America, it's closer to 30%. In, for example, South Korea, it's closer to 70%. And there are some reasons for this that are beyond the scope of today's discussion. But in any case, this is the most common genetic alterations in papillary thyroid carcinoma, BRAF V600E. The second most common is RAS. There are 3 RAS genes that are very similar in the function and morphological and biological properties. Then when we talk about gene fusions, about 15% of papillary thyroid carcinomas develop through the mechanism of gene fusions. You see there is minimal overlap between mutations and gene fusions. Why? Because they activate the same signaling pathways. And then finally, the third type of driver events is copy number alterations. They may coexist with mutations, not really with gene fusions, but also represent a unique event in thyroid cancer. So what is really important to keep in mind that when we are talking about this event, first of all, we know driver mutations that occur in almost all papillary carcinomas, 95, 97%. But it's also important for us to keep in mind that some of these events can overlap. For example, some of mutations may have early drivers. And I want also to mention that all of these events, BRAF, RAS, gene fusions, likely copy number alterations in certain proportion of tumors are early drivers. This is the first genetic hit that leads to tumor development. And some of them are late drivers, and one of the late drivers is TERT, for example, that can, and we are going to talk about it a little bit later, that can coexist, can develop in tumors that started as BRAF or RAS-driven papillary thyroid carcinomas. Also, this has been discussed already here, and I just briefly summarize. So all papillary carcinomas fundamentally, biologically, we can subdivide into BRAF-like or BRAF V600E-like and RAS-like. And this is very important subdivision, not only based on histology, because RAS-like tumors are mostly follicular variant papillary carcinomas, and BRAF-like tumors are mostly classic papillary carcinomas and tall cell variants. But again, something that was discussed before, the thyroid differentiation score is very different in these two groups of papillary thyroid carcinomas. Something that I also want to mention briefly is that although all BRAF V600E tumors fall into BRAF-like and all RAS fall into RAS-like, still virtually all other alterations that are found can be allocated to either BRAF-like or RAS-like genetic alteration. It is not 100%. Obviously, nothing is 100%, and Dr. Fagan mentions that some BRAF, for example, BRAF V600E tumors are sort of getting close in the gene expression profiles and even thyroid differentiation profiles to RAS-like and vice versa. But again, fundamentally, every molecular event can suggest or can be placed into either BRAF-like or RAS-like genetic cloud. This is also have been discussed before, that most of the BRAF V600E tumors, they have loss expression of many of the thyroid differentiation markers, and most of the RAS-like, they do have still high level of expression of thyroglobulin, NEAS, and so on and so forth, markers that are critical for accumulation of protective iron. So this is papillary thyroid carcinoma. So now, what about other tumor types? What about follicular thyroid cancer? This is a very good paper published from South Korea, actually, on the analysis of a large series of different papillary and follicular thyroid carcinomas. And let's briefly look at the findings. So follicular thyroid carcinomas, when we look at the molecular profile, It lacks BRAF V600E mutation, obviously, and it has RAS and other RAS-like alterations, kind of similar to follicular adenoma, because we know that they are probably the same tumors, just two different stages of their development. But what is interesting, for example, encapsulated follicular variant of PTC has molecular profile similar to follicular thyroid carcinoma, in contrast to classic papillary carcinomas and in contrast to infiltrative papillary thyroid carcinomas, which are mostly BRAF driven. So really, you see, although pathologically, we are spending a lot of time trying to differentiate and make diagnosis, either this is papillary carcinoma, or this is follicular carcinoma. In reality, we should think differently. We should kind of, put together papillary and follicular thyroid carcinomas and split them into follicular pattern RAS-like tumors and more classic papillary carcinoma type tumors, because biologically and important clinically, they behave in different ways. Also, this paper looked more closely at signature, at BRAF-like and RAS-like signature, and virtually all follicular thyroid carcinomas are RAS-like. Some of them fell into this category non-BRAF, non-RAS-like, which means that they're a little bit closer on the spectrum to the center, to the middle, but they are still fundamentally RAS-like tumors. So, to summarize, again, if we take BRAF-like and RAS-like papillary and follicular carcinomas and sort of put them into molecular groups of BRAF-like and RAS-like. So BRAF-like tumors are classic papillary carcinomas and infiltrative follicular variant of PTC. An important pathological feature is that they have all classic nuclear features of PTC. They're infiltrative. We know that they spread mostly to lymph node and only later to distant sites, and they lose expression of genes associated with thyroid differentiation at early stages. RAS-like tumors are follicular adenomas and follicular carcinomas when they're invasive. They are pre-invasive NIFT-P, and when they invade, you see how smooth is the border. They are still preserve this pushing non-infiltrative border. These tumors may have or may not have nuclear features of PTC, but they are all encapsulated. They spread to distant sites and virtually never to lymph nodes of the neck. So this is important to keep in mind. And they retain expression of genes associated with thyroid differentiation for longer period of time. As a group, again, I want to stress as a group. Now these are all early driver mutation. Now let's look at what happened with tumors that develop next genetic hits, develop more late driver mutations. So this is a study from 12, 13 years ago, but it was one of the first studies, looked at the iodine refractory disease. And that's for the moment, not to talk about ATC. We know that virtually all of them lose expression of radioactive iodine, but look at this poorly differentiated carcinomas that are as a whole group, all 34, only those that are radioactive iodine refractory. And if you look at comparison between the two groups, you'll see that the RAI refractory tumors are enriched in BRAF mutation and combination of BRAF with AKT. This is one of the late hits. You see, this study was performed before other secondary late hits such as TERT mutations have been discovered. So how does the TERT mutation, which occurs in 5 to 10% of papillary and follicular carcinomas, affect the sensitivity to radioactive iodine treatment? There are several studies for now. I'm just going to discuss this one published several years ago in 2017 from China on 66 patients with distant metastatic differentiated thyroid cancer. Clinically and biochemically, the completeness of response to iodine therapy was evaluated. Patients were followed for 46 months, and they look at the impact of molecular profile on sensitivity to radioactive iodine treatment. They look at overall, this diagram reports the main results. If you look at TERT positive, TERT negative, they observe that almost all TERT positive tumors did not really respond to radioactive iodine. And for the one TERT negative, there was a mixed bag of findings. But when we, but on the here on the right, there is a more sort of granular diagram that is very important. When we look at combination of BRAF and TERT positive tumors, 10 out of 10, it's not very large cohort, but 10 out of 10 were pretty much resistant to radioactive iodine treatment. For BRAF negative TERT positive tumors, that also observed that most of them were non-responsive. Then BRAF positive TERT negative tumors, most of them didn't respond, but a significant proportion of them responded. And for markers that were negative for both, we observed, they observed that most of them responded to the treatment. So this is one of the papers, again, sort of summarizing overall that if we are talking about this disease as a group, so BRAF and TERT are tumors that mostly more represent the radioactive iodine refractory disease. I mean, and the proportion of these patients decreases with loss of one or two of these genetic markers. So this is a relatively small but very telling series of patients with thyroid cancer presented with distant metastasis to the bones that was published from the University of Utah recently. They had 7 patients that presented first with distant bone metastasis and later found that the origin, the primary tumor was located in thyroid. It was an interesting group. In fact, 2 microcarcinomas, papillary microcarcinomas gave, distant mets. But let's look at the molecular profile. 7 out of 8 of them were positive for TERT, and the majority were RAS positive. So RAS TERT was the most common phenotype, genotype, and 1 case was positive for BRAF V600 mutation. Okay. Tumor size, gender, and on the bottom here is a radioactive iodine uptake. And as you can look at this sort of findings, only 1 case didn't metastatic foci didn't uptake radioactive iodine, and this was a BRAF TERT positive tumors. Remarkably, every other patient had radioactive iodine sensitive disease, including those that had RAS and TERT mutation. I think that one of the important finding of this paper, of the series, indicates that TERT still by itself is unlikely to determine the sensitivity to radioactive iodine. And combination of RAS and TERT tumors still probably are expected to be responsive. But BRAF and TERT, it's indeed a genotype, a molecular signature that would predict very low possibility of responding to RAI treatment. So for a second, what about Hürter cell tumors? We talk about papillary carcinomas, we talk about follicular carcinomas. What about Hürter cell tumors? Until recently, the molecular genetics of these tumors was not known, but in 2018, we had 2 papers published that describe the molecular genetics of this disease. So these tumors, we know for a long time, they have this appearance because of the accumulation of millions of mitochondria, which are abnormal. Sort of it gives a specific granular appearance to the cytoplasm. That's how we diagnose it histologically. And we also know, and these papers confirm, that mitochondrial DNA mutations are common in these tumors. Some of them also have the bona fide DNA mutations, but not a large proportion. I'll mention briefly on the next slide about it. But the genetic hallmark of these tumors is chromosomal copy number alterations of neohaploid type. So losses or gains of full chromosomes is a highly characteristic finding in these tumor types. So we know that Hürther cell carcinoma, from our previous experience, they really have, either low or very poor susceptibility accumulation of radioactive iodine. So from the biological perspective, we have to clearly realize that these tumors have very different molecular profiles. Again, mostly driven by this very peculiar and very unusual type of whole chromosomal gains and losses. So when we look overall at the genomics of Hürther cell carcinomas, virtually none of them have BRAF mutations. And in this study, less than 10% had RAS mutations. So again, our general approach to tumors classification as BRAF-like and RAS-like would affect papillary and follicular carcinomas, but not Hürther cell carcinomas. So, like I said, most of them developed as a mechanism of copy number alterations, and there is significant proportion of TERT mutations. So, in our next sort of phase of research studies and trials, we really have to focus on Hürther cell carcinomas as a biologically and probably clinically separate type of tumors, and we need to understand better what would determine sensitivity to radioactive iodine in this tumor type. So how can we approach this in a clinical setting when we have molecular testing now to look and try to determine, to predict not only the diagnosis, but also tumor behavior and possibly susceptibility to radioactive iodine, sensitivity to RAI3. So this is just one multi-center study looking at the indeterminate nodules, and about 2% of indeterminate nodules had this high-risk group, which is typically a combination of low and high-risk mutations. Some of them were BRAF, some of them were not, such as RAS mutation. But this is a very small proportion of tumors. BRAF-like group, including BRAF mutations and MOS fusions, constituted approximately 12% of Bethesda 3/4 thyroid nodules. Virtually all of them were papillary carcinoma on resection. RAS-like group was about 60% of all positive tumors. And then again, copy number alterations, these are mostly Hürther cell carcinomas, and another group about 20%. So again, we have to start thinking about not only if molecular testing provides us evidence that this is cancer or not, but also now we can even preoperatively can detect if this is a BRAF mutation, if it's a RAS mutation, if it's a BRAF plus TERT, and hopefully eventually this knowledge will allow us to better be prepared to various treatment modalities, including radioactive iodine after tumor resection. So how often we expect to see this different type of phenotypes, including tumors that are BRAF and TERT positive, and therefore are very unlikely to respond to radioactive iodine. In this study where we had about 330 malignant thyroid cytologies, 7.3% of tumors had BRAF plus TERT mutation. This is something that this is the genotype that molecular signatures that can be given preoperatively. And when we look at a larger group, at a surgically removed tumors, this is similar to TCGA, about 512 tumors. Then when we look at BRAF and we look at TERT, about 10.3% of PTCs have the signature. So at this time, in a very general and very preliminary way, we can say that between 7 and 10% of differentiated thyroid cancers would have this BRAF V600E plus TERT mutation, which which is very likely, based on everything we know, would confer a lack of sensitivity to radioactive iodine treatment. So finally, I want to finish with a very practical question. When you have a patient who has a primary tumor removed and develop multiple or single metastatic fossa, and you are considering sort of applying radioactive iodine treatment, obviously you have clinical tools, you have dosimetry, but from the molecular perspective, when you want to address it, and so do you have to get the molecular profile of metastatic disease, or genotype in primary tumor would be sufficient to establish the molecular profile? Obviously, when there is a way to obtain metastatic focus, pathology and genetics, this is the most, obviously the most sort of telling, the most informative sample. But if you are not, can you sort of extrapolate the profile from the primary tumor? And the answer is yes. In most situations, there are a number of studies published, and this is one of them where they look at 12 patients with radioiodine refractory metastasis. So you can see PTC, a couple of them have fertile cell follicular carcinoma, and this group looked at the presence of mutation in primary and metastatic fossa. And if you look at this group, for the most part, you see BRAF, all 5 BRAFs were in primary metastasis. NTRK3 fusion, NRAS mutation was in primary and metastasis. So in this, the most of the genotypes were similar between the two groups, but not all. Some mutations, and we don't know, ATM mutations, NTRK, it's not a fusion, it's mutation. So they were slightly different. So although you do expect to see some variability in genetic makeup between tumors, primary thyroid tumors and metastatic fossa, fundamentally, it is likely that you will see all main driver events early in late, and late when you study primary thyroid tumor. So in summary, we discussed today the thyroid differentiation status and radioactive iodine avidity can be predicted based on genomic profiles, based on the presence of early and late drivers, again, BRAF-like and RAS-like, with nuances, with many, many nuances that were beautifully highlighted in Dr. Fagan's talk, but we are talking about a very general kind of a more practical approach. So we expect to find the molecular profiles that we know now confer a very low likelihood of response to radioactive iodine, which is BRAF and TERT mutation, and 7 to 10% of differentiated thyroid cancers. And importance that this can be detected using molecular techniques in FNA and core biopsy. If you cannot, it doesn't necessarily require a removal of the entire primary or metastatic focus. So expression of thyroid differentiation genes or thyroid differentiation scores may provide more accurate assessment, definitely, than just simply talking about RAS-like or BRAF-like. But it is really currently more research than a clinical tool. And although some genetic heterogeneity between primary tumor and metastasis exists, overall, the molecular profiles are similar, and in general, the molecular makeup of metastatic focus can be predicted based on the primary thyroid neoplasm. With this, I want to thank you for your attention and look forward to answering your questions during the Q&A session. Thank you.